This webinar series has been kindly supported by the company Erber Mannheim. And the webinar series is also accredited by the Royal College of Pathologists in the UK for CME points. This webinar is for 1 CME point. It is important that you register for your CME certificate before, which you can also register at this time now as well before the end of this webinar. I will post the link to the registration form in the comment section on the Facebook group if you still haven't registered for your certificate. We'd like to think that you want to see this again, this webinar. All the webinars of this series will be available on the Blood Academy YouTube page. So it'd be an opportunity to revisit the cases and the learning points that are discussed as well. This webinar series is an introduction to blood microscopy. We'll try and go through as much as we can. But if you do want to learn more in a more detailed and work at your own pace, then the Blood Academy website has a essential blood cell morphology course, which consists of video tutorials, online modules and assessments. And again, this is also accredited by the Royal College of Pathologists. We are running a discount with the Hematology Interest Group where you can save 20%. So if you're interested, go and check that out on the Blood Academy website and use the code HIG20 for your 20% discount. Okay, so today I'm going to be joined by Joe Sidey. He is based in the eastern part of Australia. Just a little bit of background before we start about Joe. He gained his bachelor's degree in medical laboratory sciences from Wollongong, hopefully I've pronounced that correctly, and Charles Sturt University in East Australia. He's got over 10 years experience as a hematology scientist, especially in the field of blood cell morphology and microscopy. He is now working as a senior laboratory supervisor at Coffs Harbour Hospital, just north of Sydney. And he's responsible for training and professional development in the team that he leads. He's also one of the hardworking admins of the Hematology Interest Group. So welcome, Joe.
Thank you, Ali.
Excellent. But before we crack on with the cases, I'm just going to put it out there to everyone that we want to try and make this webinar as interactive as possible using the comment section. And we would really appreciate to get your opinion on what the diagnosis is from the cases that we've discussed. So I'll just allow you to share your screen now, Joe. There we go.
That working?
Perfect, excellent.
Awesome.
So should we start off with case one? We've got a 42-year-old female who's presenting with slurred speech. She's anemic. She's got hemoglobin of 90. We're not given the differential count for the white cell count, but it's 4.1, the total leukocyte count, and the platelet count is 41. So I'll leave it over to you, Joe, just to go through some of the morphology. We can discuss some of the interesting issues around it.
Okay, no worries. So we've got a 42-year-old female. She has slurred speech. She has a mild anemia with a HB of 90. The white scan is 4.1. The normal range for a woman this age is 4.5 is the lower side of normal range. So it's mildly reduced, but we need to keep in mind that it may actually be a normal white cell count for the individual. And she has a moderate thrombocytopenia of 41. Okay, so let's have a look at the slide. Before we look at the slide, actually, if this is a real patient, you would definitely want to be checking the sample for a clot. In case it was a difficult collect or the tube wasn't inverted and sufficiently post-collection for the lab, the EDTA, to stop to act as an anticoagulant. So when a film is reviewed, you first want to start on low power. And because the patient has a low platelet count, you definitely want to be looking in the tail section of the film. And unfortunately, the tail section's been cropped out a little bit in the making of this virtual slide, but we'll do what we can. So looking at low power, and with a low platelet count, sometimes you can get platelet clumping that can form, which could either be due to a traumatic collection or poor collection technique. Maybe the sample is collected in a needle and syringe, and the sample is left in the syringe for a prolonged time before transferred to the anticoagulated tube, and you might get some platelet activation. Not enough to make a clot form, but the platelets still might aggregate together. So we're just having a look at low power, having a look around at our sort of tail to see if we can see platelet clumps. And we can't see any. So what platelet clumps would look like would be light blue aggregations of platelets, and maybe like from this, like small bundles of grapes, kind of. So we can't see any platelet clumps. So we're going to believe this platelet count is accurate. And also, when you're looking at low power, it's good to assess the whole slide to see the quality of the smear. You probably don't want to see large ridges. No, you can't. Large ridges of thicker areas of film where the red cells and white cells come together more, and then thinner areas, because when you do your differential, you may not get an accurate differential of your white blood cells. But now we've assessed that it's a well-made smear and that there's no platelet clumping. So we'll go into a higher power, probably something about 40 times or 20 times that you're used to in your laboratory. And the very first thing that would jump out at you is the quite irregular red cells. As you can see here, there's this red cell we call this hyperchromatic, where you no longer see an area of central pallor, which is a lighter area of the red cell. And it's also lost its circular shape. And it's become this sort of two pointed ends at each side. And here's another cell with pointed ends. And it's got a slight area of central pallor, but it's starting to lose its central pallor. And we'll also see there's lots of these crenated cells, or echinocytes, as they should be called. So the most prominent features for the red cells that we can see are definitely these cells that have pointed ends and with a lacking central pallor, hyperchromatic, and these are called fragmented red cells, or preferably schistocytes. And there's lots of these cells with crenation. And also on the blood film, there's this cell here that has this dark purple, like it's more like a miniature nucleus. That's called a Howell-Jolly body. Other red cell features that are presented on the film, here is a cell that has no central pallor next to a normal looking red cell. And so this would potentially be a spherocyte. And sorry, I'm a little bit nervous, so I jumped a little bit ahead of myself. When you're looking at low power, you should also, before you dive down and look at the more high powered field, you want to find the ideal area of thickness, or a monolayer area of the blood film. Dan Pelling talked about this in the webinar number 1. So the ideal area of thickness is an area on the film where the red cells are evenly distributed, or hopefully evenly distributed, and you start to get some overlapping of the red cells. And it's the best area to examine for red cell features, white cell features, and also platelet morphology. So we'll dive back down into the high power field, and we can see lots of these cells that are hyperchromatic with pointed edges, and they also can be quite spiculated and crenated as well. These schistocytes, which is not uncommon to see when they're formed. And there's also some polychromasia. It's not overly prominent, but there is a higher than normal amount of polychromasia. So every high power field, we're seeing a polychromatic cell or two. And reviewing polychromasia, polychromatic cells, let me just start again. Polychromatic cells are these cells that have this red cells that have a purple appearance, and they got basophilic and eosinophilic staining characteristics due to the higher RNA content of the cell. And they're immature red cells. And in the red cell maturation sequence, in the marrow, you have erythroblasts. They mature down into nucleated red cells. And then the nucleus undergoes like an apoptotic process and then gets extruded from the cell. And you still have red cells that have lots of ribosomes and RNA in them. And on a peripheral blood film, they're immature, but they would stain this polychromatic appearance. So they would have eosinophilic pink, red, and basophilic blue and purple staining characteristics, unlike mature red cells. They just have this eosinophilic staining characteristic. And the degree of polychromasia on a film doesn't always directly correlate to the number of these immature red cells, which are called reticulocytes. So a reticulocyte count, whether it's manual or automated from an analyzer, is the best way to report the actual reticulocyte concentration and percentage for a full blood count. So at my laboratory, we don't get too carried away with grading the reticulocyte level. We just report, if we see enough that we believe it's significant, we just report that there would be significant polychromasia present on the blood film. So to summarize the red cell features that we've been seeing on this blood film, there's significant numbers of schistocytes, and schistocytes are these cells with pointed ends, and they're hyperchromatic, and they can also be a little bit crenated, so don't let that throw you off. Like this cell, it's got two pointed ends on the polar ends of the cell, but it's also quite a couple of bumps along it that are crenation. And say this one, there's still a schistocyte. Lots of crenated cells. Crenated cells can be the product of abnormal renal function, like acute kidney injury. They could be due to improper sample storage, like heating the sample, or the sample being left at room temperature too long. It can be that would be an artifactual change. Another artifactual change is if it was a difficult collection and there wasn't much blood in the EDTA sample, the EDTA may cause crenation of the red cells. Generally, in those situations, you get a uniform appearance across the whole blood film of crenated cells. Schistocytes, that is the other most significant thing. They're the herald of a microangiopathic process or mechanical hemolysis occurring in vivo inside the person's body. That could be due to a damaged heart valve, and the high forces applied to the red cells when they're passing over a damaged valve, they're causing the red cells to tear, or a prosthetic valve that has fibrin or is damaged or has fibrin starting to form on it. And then the high shearing force, the high flow across it from the heart pumping, will start tearing the cells. And the cells get a tear in them, and because they're a bilipid membrane on there, they'd love to reform after they've been damaged, but they've lost their structural integrity and they form this elongated cell with two pointed ends. And there's the other thing I talked about was a microangiopathic hemolytic process. So microangiopathic is dysfunction of the small vascular system. Hemolytic, just rupturing or destroying of red cells. And anemia is a low hemoglobin or red cell count, or just process. It's a dysfunction of the microvascular system that's causing mechanical hemolysis, essentially. And I won't go too much into why we're seeing these on the film to the end, because I don't want to give too much away. But one thing to remember when you're looking at a blood film is we're getting quite excited that we're seeing all these very significant red cell morphologies, and you know, ooh, this might be actually textbook case for something very significant that every good morphologist should know. However, we shouldn't get too carried away and forget to look at the white cells and the platelets, because every single blood film review, a good morphologist should be reviewing red cells. What are significant morphologies we're seeing? Is there any? If there's not, should we be reporting these minor morphologies that we might see that might not have any clinical usefulness to the clinician referring for the full blood count? What's going on in the white cells? Is there any significant morphology we can see? Is there any cytosis, high cell counts, any cytopenias, low cell counts for the white cells? And what are they? Is a manual differential required? Can we trust the analyzer's results? And the platelets, is the platelet count accurate? Is there something going on, like platelet clumping, that we looked at straight away because the platelet count was low? Can the platelet count be trusted? Is the analyzer platelet count accurate? If the method used for the platelet count to determine the platelet count is an impedance method on an analyzer, large and giant platelets might be inaccurately counted as red cells, or even very small red cells, fragments or microspherocytes. They may be counted as platelets. And in a case like this, where we've determined, yes, there's no platelet clumping, so we want to trust the analyzer's result. Is there enough very small fragmented red cells like this? Is this potentially causing a falsely high platelet count for this case? And that's where maybe if you have an analyzer that can do an optical or fluorescent platelet count, it might be able to give a more accurate platelet count. And you might not have to go down the rabbit hole of performing an indirect platelet count or a platelet estimate. You can trust the superior methodology of the analyzer doing an alternative platelet count method. That's if you're lucky enough to have a laboratory with optical platelet count or fluorescent platelet count. So, like I was saying before, I'm digressing. I was saying before, it's best try not to get too swept away with the very significant red cell morphology you're seeing in a case like this. And remember, you always need to assess your white cells and platelets. So we'll move on to white cells. So the white cell count was 4.1, which would be mildly reduced for a woman of 42 years old, at least for my laboratory would be. Maybe not for yours, but the most prominent cell, most numerous white cell we're seeing when we're looking across this blood film is mature neutrophils. And I'm not going to go ahead and do a manual differential because that'd be a little bit awkward and difficult, but it looks to me like there's about 80% like 4 out of 5, maybe, or maybe a little bit more of the white cells are mature neutrophils. So it's pretty safe to say that this patient has a normal neutrophil count, where a neutropenia would be something below 1.5, and a neutrophilia would be above 7.5 or something, and the white cell count is 4.1. So it's probably around about the 3.5 mark. So it's a normal neutrophil count. Now, the neutrophils that we're seeing, now we have to examine them morphologically. So we can do that by the lobulation. Have they got a mature neutrophil normally has 2 to 5 lobes. Is most of the neutrophils have 2 to 5 lobes, then that would be considered normal lobulation for the neutrophil. And going off this film, it looks like that is the case. And then there would be granulation for the neutrophils. Is there toxic or hypergranulation or increased granulation, which might be a reactive process to infection or inflammation? Or maybe a drug, a therapy that they've been given? Or is there hypogranulation or agranulation? That's when a neutrophil has reduced numbers of primary and tertiary and secondary granules, or an absence of granules, and that would be a dysplastic feature, which suggests that something has gone wrong in the granulocytic maturation sequence in the marrow, which would point towards a dysplasia, a myelodysplastic syndrome potentially, or a myelodysplastic myeloproliferative neoplasm, like myelodysplasia or CMML. But the neutrophils in this patient, on this patient's blood film, have normal granulation. It's not overly increased or darkly staining. You can definitely see there's granulation there. It's not hypergranular, so I'm happy to say that these neutrophils look happy and healthy and normal for an individual. Now, there's not too many lymphocytes that we've seen, but the ones that I have seen have been well differentiated. There's been a couple of lymphocytes with a bit more abundant cytoplasm, and there's been a couple small mature lymphocytes. So I haven't seen much reactive processes in lymphocytes. Sorry about. I've got suboptimal internet at my home, so we might get some buffering issues from time to time.
I was just going to mention that we've got some comments coming in about the diagnosis.
Okay.
We've got a range of things in that. This is could be TTP, HUS, DIC.
Yep.
And we've got some comments also saying that this could be, as you've mentioned, microangiopathic hemolytic anemia.
Yep.
One interesting question really is, we noticed some red cell agglutination. Is that significant, or could that just be due to where the where we've sat on the film? It could just be
not looking at the right spot on the film, but yeah, that's keen eye. I completely overlooked that. Kudos to the person that pointed that out. So I was a little bit nervous when I first started there, and I jumped straight into it and didn't talk much about looking at the ideal area thickness or the monolayer of the blood film. So on low power, so a bit too low power, we want to be able to see some of the white cells and red cells. So we want to go down and look at where the red cells start to overlap, but they're evenly distributed as best as we can get, especially with a patient that has a hemolytic process going on or anemia. They can be sort of haphazardly, like little gaps every now and then in the blood film. It's hard to really find that area that is a good ideal area of thickness, but I'm happy about here, where there's some I stop pointing with my finger and I start using the cursor so you can see where I'm looking at. Sorry, guys. There's some red cells starting to overlap, but the majority of red cells are sitting by themselves. And as you can see, they're not really evenly distributed, but there's sort of areas here that there's a gap, and we can, like, I think where I was looking at before was too thick in the blood film, where you start seeing this pseudo rouleau formation, which is like, rouleau formation is when, think of it as like cells sticking together end to end, looks like a pile of coins that has been tipped over on a desk, and this, or poker chips that has just been knocked over and they sort of form a stack, or like Oreo biscuits laid out on a serving platter. So we're not seeing that, but if you go too far in the area of thickness, you might start seeing agglutination, which is different to rouleau. It's red cells sticking together like rouleau, but it's more haphazard and like a bundle of grapes or frog spawn or fish eggs. So I don't believe there's agglutination in this film. So
I always find it a challenge, Joe, that when you're so anemic, that the film, depending on where you go, it can be quite difficult to see what the monolayer is, where that sweet spot is. But I think just keep going up to the thinner part, and you'll see the agglutination disappear. Really, so thing there. So I mean, this looks like a really scary film, and it's something that needs to be actioned straight away. In terms of the sort of, would you put a percentage? Is there a significant number of schistocytes that should prompt concern, or?
So my laboratory, our standard operating procedures for reporting blood films, we don't grade red cell morphologies. We only comment on when there a significant morphologies had been identified. But I am familiar with like the grading system that hopefully most laboratories are using by is it ICHS or ICSH?
Yeah.
So schistocytes sort of fall in their own sort of category, where you can only see if you see a small number of schistocytes with a low platelet count, it's considered very significant. Like this case, as a couple of the viewers have pointed out, that they believe that it's a microangiopathic hemolytic anemia, and some people are pointing towards DIC, disseminated intravascular coagulopathy, or TTP, thrombotic thrombocytopenic purpura, or HUS, hemolytic uremic syndrome. All TTP, HUS, and DIC are scary things, and they're all three of them are genuine hematological emergencies where you really want to action these results quickly and accurately to the referring clinician, and hopefully give them some good advice.
Definitely.
So, I mean, if I had a moderately low platelet count with 2 to 3 schistocytes per high-powered field, I'd be very concerned. And this film, I'm seeing like dozens and dozens per field. What do you want to? Sorry for cutting you off.
So no, I was just going to say about the Hal Jolly bodies as well. I mean, it's a bit atypical for sort of Maha process. Is there any way we could explain that?
Oh yeah, so this looks like an acute process. So it's something that's suddenly onset a patient, and so I wouldn't normally expect to see Hal Jolly bodies in a film like this. You could see Hal Jolly bodies in a film with a patient with acute or a hemolytic process where the spleen's function is to filter damaged and aged red cells from the body, and it's sort of getting overwhelmed. So you get a small number of Hal Jolly bodies formed naturally from production erythropoiesis in the marrow. They come into the blood supply. But in a healthy individual, they get the how jelly bodies get extruded by macrophages in the spleen quite quickly. But if the spleen's getting overworked and getting tired due to all this hemolysis and damaged red cells that are about, I would expect some to start slipping through the cracks, and you would might be able to see a couple on the blood film. Or this patient might have a complicated medical history, and they might be like splenectomized previously, and it's just a coincidental finding on this blood film, maybe. I don't know. Do you have anything to add, Alan?
No, I don't. I mean, I think just answering some more comments on the comment section, the significance of the percentage. I think 1% generally is significant of all red cells.
Yep.
And in cases that I've seen, at least, that this is very, very obvious, but in some cases it can be quite subtle as well. So there was a move previously to monitor the percentage of schistocytes with treatment, but now that's been overseeded by other techniques, really, in patients with TTP, really. So I don't know if I could just give my comments on the sort of the clinical side of it, because
go for it.
You see a film like this, really, it needs to be action straight away, and you know, the team who's looking after the patient needs to be contacted, because the differential diagnosis is so wide, and really have to correlate that with the clinical picture. And there could be things like, as you've already mentioned, things like DIC, TTP, HUS, even things like preeclampsia can cause this. So the clinical history is really important to sort of differentiate what we do next, really, and what it could be. And then you're looking at your basic tests to confirm hemolysis, your reticulocyte count, your LDH, etc. And then if you're strongly suspecting that this could be TTP, a good differentiator between that and other conditions is doing an Adams 13 level, really. So I know in some places it's not that easy to get to get an activity level. So really trying to get things rolling, because especially in TTP is a very treatable condition, and the outcomes are very good, really, if provided the patients are treated quickly. So time is of the essence. I think, as you mentioned, this is a medical emergency, and get things moving quickly, really. So so I think that's an excellent start, Joe. Should we move on to case 2?
Yep, if you're happy.
So case 2 is a 70-year-old female who's having a routine blood count as part of a pre-op for knee replacement. Hemoglobin looks okay, 115. The white cell count is 8.5. Again, should be within the normal range. And the platelet count is low. We've got a common theme here. It's reported by the analyzer at least at 31. So I'll hand it over to you, Joe.
Yep, no worries. Okay, so the platelet count was 31. So like I talked about the first case, should we be trusting this result? There's a couple of checks we can do. Number one, check the sample for a clot. If the sample is clotted, look for an alternative EDTA sample that may have been collected, and see that's clotted and run it. Or if it's clotted and you don't have another sample to use, organize a recollection. Or maybe the platelet count may be inaccurate because there might be platelet clumping or platelet satellitism. That's where the platelets stick to the outside of neutrophils, mostly, that you see, and they're stuck to neutrophils in the sample, just on the blood film. And when they go through the analyzer, they don't get picked up during the platelet count. And platelet clumping, one big clump of 10 to 15 platelets is counted as one platelet, or might even be counted as a white cell or something in the white cell count. And you get a falsely low platelet count. So if the sample's not clotted, you make a peripheral blood film, dry it, stain it, examine it. And when you examine it, first in low powered, and you would look at the feathered edge, and you'd be looking for platelet clumps, and on low powered. And I mentioned before, they look like irregular shaped light blue purple splodges or bundles of grapes. And this is a textbook case of platelet clumping. And we'll zoom in on high power just to have a look at it and wait for my slow internet to buffer and load it. So we can see there's lots of little platelets all aggregated together in this big clump. And when the analyzer has done the hydrodynamic flow for like an impedance platelet count, these would go through as these big clumps and probably not even get counted as platelets, probably get counted as white cells or nothing because they're even too big. And you would get this falsely reduced platelet count. So the platelet count of 31 is definitely not accurate. So a good morphologist and hematological scientist for a low platelet count, that's a new presentation, should always be reviewing a full blood count, peripheral blood film, just because if you're inaccurately report a low platelet count, a clinician may make a clinical decision on that and start treatment. If they believe the patient might have something like ITP, they might start them on corticosteroids or something. You don't really want that occurring. Or maybe the platelet count was 5 or something, and they might send them to an emergency department, an ED, and order a platelet transfusion. And we don't, and if transfusions, regardless of the red cells, platelets, or plasma, always have an inherent risk associated with them. It's not a perfectly safe practice. And we want to avoid this best we can. We want to provide quality work, quality results, yeah. Okay, so this is a textbook case of platelet clumping. And platelet clumping can be due to 2 things predominantly. So it could be due to a in vitro phenomenon where the platelets aggregate together due to an autoantibody. I'm sure everyone who has done a bit of study in medical laboratory science and hematology has heard about EDTA-dependent platelet clumping. And that is where there's an autoantibody that in vivo inside the body doesn't cause the platelets to clump, but when it's exposed to EDTA anticoagulant, the antigen on the platelets that causes the antibody to cross-link and make all these aggregates to form gets changed slightly with the presence of EDTA, and it allows this autoantibody to actually cross-bind the platelets together and it forms clumps inside an EDTA tube. There's also clumping that can occur. Platelet clumping that can occur in vitro that is not it's not EDTA dependent, and we'll talk about a bit that later. But you can also get platelet clumping due to improper phlebotomy technique or a difficult collection, like someone's got a hard vein to access and someone's really struggled and tried their best. So, and they've gotten some blood, but it's been traumatic or it's been delayed transferring it to the EDTA sample, and some platelet activation has occurred and partial coagulation has occurred. It might not be enough to form a physical detectable clot in the sample or detectable sticky fibrin strands. Like the way you look for a clot in an EDTA is wooden applicator sticks, 1 or 2 or 3 of them, stick them to the sample, swallow, go fishing about, pull them out, have a look, and you might pull out a big nasty clot or a couple of little clots, or maybe the blood's just extra sticky and some sticky filaments that stringy strands that are sticking to the wooden sticks, and they're called fibrin strands, and that's a clot is started to develop. And I would highly recommend how you action and troubleshoot these, follow your standard operating procedures or your procedure manuals for your laboratory, because how to troubleshoot platelet clumping varies wildly from laboratory to laboratory. And we get this on the hematology interest group when people discuss this. And some people are very relaxed about it, and they will give a qualitative analysis, like report of they think platelet coming, or there might be a hospital lab and you have quick access to a patient and you would organize a recollect pronto, like you can. And if you think it might be, and collect it in conjunction with a citrate sample, maybe, or turn a new blood tube. But I'm sort of diving into discussion of the case when Ali asked me not to.
No,
Okay, so let's just get back into reviewing a blood film. So as I mentioned in the case one, it's best, you got to remember not to get swept up in just thinking about the platelets in this case because there's so much clumping. We need to assess, like, we've got a blood film here and we're probably going to be reporting results. So we need to review this film because there can sometimes be some insidious morphology that can be lurking in a case, and we don't want to get too relaxed just because we think, oh yeah, we're reviewing blood film because the platelet count's low. We said there's clumping. There could be something going on, like, you never know, like there might be malaria hiding in a couple of these red cells, or it might be a couple of blast cells, and someone's developing a myeloproliferative neoplasm or a leukemia, or they might be abnormal lymphocytes, and you might catch something. You might find Sézary syndrome or something. Like, you never know. So it's be a diligent morphologist and always review your 3 cell lines when you're looking at a blood film. It will add a little bit extra time, but one day in your career, you will pick something up and you'll be pretty proud of yourself and pretty chuffed. So, okay, so we're looking at this on low powered, and we've detected these platelet clumps. So now we're going to assess the quality of the smear. This looks like disregarding the platelet clumps, quite a well-made smear. The white cells look evenly distributed. The red cells look evenly distributed. There's no big columns of thicker bands of red cells and white cells. So now let's zoom in a little bit more to try to find this monolayer or ideal area of thickness we were talking about before. So we want to start seeing red cells being evenly distributed, and also some red cells starting to overlap. And I think I've got it now. So the red cells are mostly distributed and separated, but we can see that there's some red cells starting to overlap. So this is the perfect area to perform a differential. The white cells will be evenly distributed, and the red cells will be able to see the morphology clearly. If you go too thin of an area of blood film, the red cells start to lose their central pallor, and you might be over calling spherocytes or inappropriately reporting spherocytes. If you go too thick in the film, you might start seeing rouleau formation when it's not necessarily there and it's not significant. Or you might start seeing what you think might be agglutination, and then you go troubleshoot it and follow your procedure manuals, and you start warming samples thinking it's cold agglutinins, and you waste the 20-30 minutes of your time. So it's always good to look at the ideal area of thickness. So let's start off with the red cells. The red cells here are normal in appearance. They're circular in shape. They've got a central pallor. There's occasional crenated cells and irregular poikilocytes, and there's a little fragment here. But as Ali was talking about before, like, you got to look at the whole picture. Like, every field of view here we're looking at, there's a couple hundred red cells, and we've seen one crenated cell in a couple of fields. We've seen one irregular fragment and one irregular poikilocyte that I couldn't name so it's less than 1% for these things. So they're not really significant, and the red cells appear normal in size and shape. So I said the normal in size. To do that, I would find a small lymphocyte because a MCV wasn't provided in the full blood count results. And here's a small lymphocyte. It has a small amount of cytoplasm, which is ideal, and it's got a dense and compact nucleus. So a normal red cell, I believe, is about 7 to 9 micrometers in diameter. I may be wrong there because, yep, I haven't really looked that up recently, and it's something I don't use in day-to-day running and reporting of blood films, running a laboratory and reporting of blood films. But a red cell should be the same size in an adult human. A red cell should be the same size as the nucleus, or maybe a little bit smaller. And here's the nucleus. It's about from here to here. And this red cell is about the same size, just a little bit smaller, but I'm confident to say that these red cells are normal in size, normal in shape, and normal in hemoglobin concentration because they've got a small area of central power. So we would call these normocytic, normochromic red cells. So now we'll go looking at the white cells. So the white cell count for this patient was, I believe, 8.5, which is upper of the normal range. So it's a normal white cell count. Zoom out a little bit just so we can quickly assess the numbers of different types of white cells. The predominant, most common white cell in this patient is neutrophils. These multilobular white cells with granulation. There's 1, 2, 3. So it looks like about 3 and 4 of the white cells are neutrophils, and a normal neutrophil count is anywhere from about 1.5 to 7.5-ish. Like the ranges vary from laboratory to laboratory, but I'm happy to say that this neutrophil count is normal, so they don't have a neutrophilia or a neutropenia. And also for the neutrophils, you would look at the lobulation, the chromatin pattern, and the granulation to determine whether might be a reactive process going on there, where you would get an increased granulation neutrophils, or vacuolation, or if there might be a deficiency state or a medication given to the patient, or a dysplastic feature where you may get a hypolobulation, so reduced number of lobes in neutrophil. And you can also get a hypolobulation where you get band forms in a reactive process. A band form is where there's one lobe and it's stretched across the cell, and it often forms a C shape or an S shape or even a straight line. So these cells, there do appear to be a few bands. But given the other neutrophil features I'm seeing where there is a little bit of granulation, it's not increased. The granulation isn't overly stained dark. So I would say the granulation is normal for these neutrophils. I can see granulation in majority of neutrophils, so I wouldn't say it's hypogranular, which would be maybe herald a dysplastic process going on in the marrow. But it doesn't seem to be any obvious reactive changes in neutrophils, and there's not an overly high number of band forms. So I would be comfortable not going into reporting those if you was part of your procedures. Sorry, it's going to take a little bit of buffer. So, and the lymphocytes. The majority of lymphocytes are small, mature lymphocytes. I haven't seen any reactive lymphocytes, and the monocytes look normal. So I'm happy to say that the lymphocytes, the white cells there's no significant morphologies that I can see with the white cells. And the platelets, we saw the platelet clumping, but however, you should also have a look at the platelets to see if there's significant numbers of large platelets and the granulation of the platelets. Which might point towards an acquired condition like mild dysplasia or some dysplastic process, or a myeloproliferative process where you're getting large platelets forming, or maybe a congenital inherited condition where you can have large platelets. And granulation, you can have hypergranular platelets or irregular granulation in platelets where it all gets you got a large platelet and all gets pulled to the center, pulled in the center of the platelet, not evenly distributed. So yeah, it's quite tricky, but the platelets appear relatively normal as well. Like I saw a couple of large ones, but there wasn't enough. Like a good rule of thumb is large. Well, I should also just explain what a large and a giant platelet is, because a large platelet is a platelet that is, I think of it as greater than a third of the size of a red cell, up to the size of a red cell, a normal red cell. And a giant platelet would be larger than a normal red cell, size of a white cell or larger. And you only need to see a couple of giant platelets for it to be a significant finding that you may want to report on, or refer to a hematologist or pathologist for a second opinion and let them know that you've seen it. And large platelets, it's recommended by up to 20% of the platelets, 1 in 5. If 1 in 5 of the platelets are large platelets, then it's something significant and should be commented on, or at least referred to a pathologist for a review. So yeah, so now I guess, Ali, did you want to start discussing troubleshooting, or how we would think about reporting the platelet count for a patient that has platelet clumping in this fashion?
So I mean, this is a really obvious case. I mean, this is quite an extreme one, similar to the previous case. A lot of cases of platelet clumping probably won't look as extreme as this, and you may see the odd clump here and there.
Yeah.
But generally, it's like you said, Joe, that for the clinical team, you want to make sure that they get you want to find out why they've done it. You know, what could there be a clinical reason that it's not mixed properly, or there was a traumatic venipuncture, and really getting another sample in a citrate or heparin bottle.
Yeah.
Using an alternative anticoagulant. I mean, sometimes, I mean, I have been in some scenarios where you can get platelet clumping even in alternative anticoagulants, and they're really challenging. There's a question about what happens if you get clumping in a citrate or heparin. There's no clear answers to what to do, because even things like platelet counts by flow cytometry, they'll still be clumped because you're still using the same thing. And it's really just doing there is some evidence that there could be a difference between optical and impedance analyzers, and whether they're better. But it's a real challenge. I think you're looking at morphology to see whether the platelets are actually there or not. And you have to put your hands up and say, well, we can't give an accurate platelet count. So from a clinical perspective, the only thing that I would add to your really good point, that you don't want patients to be treated unnecessarily for things like ITP, but equally you don't want patients not to receive some treatment. So I've seen some cases where physicians have not given things like heparin as thromboprophylaxis when they're in hospital because they think the platelet count is too low. So there could be harm by giving treatments and not giving as well than this. So it's a good relationship with the guys who are looking after the patients to get another sample, really. So should we move on to case 3?
Yeah, were there any questions for this case?
I don't think there was any other questions. We've got some really good comments about what we would do afterwards in terms of using alternative anticoagulants. We've got one comment saying that sometimes cold samples that haven't been warmed up properly can show clumping as well. So, but most people got that this was EDTA dependent agglutination. So that's really good. Perfect. Should we move on to case 3?
Okay.
So case 3 is a 13-year-old girl who's the clinical details that we've been provided are bruising. She has slightly anemic, which could be relatively normal at this age. Hemoglobin is 109. White cell count is within the normal range at 6.1. And the platelet count is not surprisingly low at 81.
We've got a bit of a theme going on here.
So I'll hand over to you, Joe.
Okay, no worries. So just like with the other ones, you want to first thing you want to determine is the platelet count accurate or not? Is the sample clotted? Is it platelet clumping? Is it platelet cellulism? So I'm sure you're all getting the gist of it by now. So when you review your peripheral blood film, stained film, you want to look on low powered, and you would start looking at the tail, the feathered tail section of the film. Look at platelet. So fortunately, we haven't really got much here, but there's a little bit here where this is the side of the tail. So we'll have a bit of a look over here. So there's no obvious platelet. No, so we can't really see any platelet clumping here. So, and also looking on low powered, you should be able to notice platelet satellitism it was forming. That's when there is a similar auto antibody that only causes the platelets to adhere to the cell walls of white cells in the presence of EDTA or other anticoagulants. And on low powered, you would see these rosette sort of rings of platelets around the white cells, and we're not seeing that here. So we can safely say we can relatively trust this analyzer count of 81 for the platelets. So that's a moderate thrombocytopenia. So then you would want to look for the ideal area of thickness or monolayer on the blood film. Start from the feathered tailed end of the blood film and work your way thicker to the body of the blood film. Start where you see the red cells begin to overlap, but are still uniformly distributed. And you'll zoom in a little bit or go to a higher powered objective and start having a scan about to see what you're working with. So when a patient has a low platelet count, before you even start looking at the film, you can start thinking about what are some potential causes. A common cause of low platelets would be transient viral infection, and you may cause a decrease in thrombopoiesis or just usage of the platelets and aggregation of platelets in the body and a decreased platelet count. And you may expect to see reactive lymphocytes. So reactive lymphocytes might be something to look for. Maybe in an infection or inflammatory process, you might get some sequestration of platelets and reduce platelet count. So let's start having a look at the white cells first. And so the white cell count was 6.1, which is normal. And the most common white cell we're seeing is mature neutrophils. So we can say that and a normal neutrophil count is about 1.5 to 7 or 7.5. So the white cell count was 6.1. So they cannot have a neutrophilia. And there's enough neutrophils here that they definitely don't have a neutropenia. But these neutrophils, so it looks like there's a slight increased granulation. Maybe not enough for me to say it's a hypergranulated. They've got normal lobulation, but there's this area here, which is light blue colored staining, basophilic staining area of the neutrophil. And these, when you see them, they're called Dole bodies or Doley bodies. I pronounce it Dole bodies, which is a rough endoplasmic reticulum in the cell, and it stains a basophilic blue color. And it's due to normally a reactive process. The neutrophils wants to make a lot of granules, fight an infection, get involved in inflammatory process, and you get this light blue staining splotchy area in a neutrophil. So yeah, so the granulation does look a little bit increased, but this can change from different stains to different stains. So it may be normal in this case. So we'll move on to assessing the red cells. And if I see any other white cells that I believe have significant morphology when I'm scanning about the film, I'll stop and I'll point it out. But the red cells, there's a small central pallor area, central pallor So they look normal chromic. And we don't have an MCV, but it might take me a bit of time to find a small lymphocyte. So we're just going to presume for now that they're normocytic, so they're normal in size. The patient was mildly anemic, or could be normal for the individual, but we're just gonna, and there's no obvious abnormal poikilocytes. There's an occasional cell here that looks a little, might be a spherocyte, but there's not very many of them. So if I wasn't seeing a couple, I'll go better area thickness further up in the film. I'd want to see 1 or 2 per field for me to start getting quite concerned, thinking that maybe there might be an autoimmune hemolytic process going on, which spherocytes may entail, might point you towards. And one way to troubleshoot that would be to do a Coombs test, a DCT, and if that came up positive, then maybe there might be an autoimmune hemolytic process going on. But I don't think that's the case. So there's no significant numbers of abnormal poikilocytes. That's a poikilocyte is a abnormal cell shape for a red cell, and they're normocytic and normochromic. So let's move on to the platelets. So I mentioned in the case before that large platelets are about 1/4 to 1/3 size of the red cell to the size of a red cell. And you need to see about 20% or 1 in 5 of the platelets need to be a large platelet for it to be deemed significant. Well, that's in my professional opinion. But so these are definitely large platelets. And just go, these are, they're getting onto large platelets. So 1, 2, 3, 4, 5 out of, over 50% of the platelets that I'm seeing are large platelets. So that's quite interesting, really. So, and we're also seeing, what was it? The clinical notes was a bruising. So the clinician is querying, does the patient may have a bleeding tendency, unexplained bruising. So they've ordered a full blood count, probably with a barrage of other tests, like a coagulation studies and ELFT for checking for liver function, to see maybe we can find a cause for this bruising. So large platelets and neutrophils with these doll-like bodies, but doll bodies are generally irregular in shape, but normally round or oval or a amoeboid sort of appearance, like a splodge. But if you have a look at these neutrophils, well, this one's a bit of a splodge, but they're more elongated rod shaped, is basophilic light blue staining, which is interesting. Sorry for my poor internet, it takes a while to buffer sometimes to load the image. I'm not really convincing myself here. I'm looking at these ones, I'm like, it's a bit of a splodge. But yeah, so so it's not, there's the interesting morphological features I've seen in this film are the large platelets, and we should talk about the granulation. So they're well granulated. We're not getting a pooling of granulation in the center of the cell with a granular ring of cytoplasm in the platelets. So they're normal granulation. So now we're going to be asking ourselves, here's a nice giant platelet. What could be going on here? Could this patient have ITP, an idiopathic thrombocytopenic purpura? Or could there be something else going on? They're a 13-year-old female, so adolescent. They probably haven't had many blood tests in their life. This might be a first finding. So I don't want to give away the answer here, Ali. has there been any comments about what maybe might be going on here?
There have been. So, I mean, we initially, when we started off, I think the comments were very much, could this be ITP? Could this be infection? And I think as we zoomed in and looked at the details of the platelets, the large size, good granularity that they display, but especially with the neutrophil and the dull bodies, we're getting more of the possible May-Heglin.
Dull-like bodies.
Dull-like bodies. And I think it's a really sort of interesting case, this one, because I think it's the point that you made is, well, have a look at a previous count. Has it been low before, and what else is going on?
Maybe this is a very first blood count we've seen for this individual as well.
Yeah, and it can be difficult, but just looking at the if you just go back to the neutrophil again, Joe. What make you, because I mean, one of the possibilities that we see dull-like bodies in things like sepsis, inflammatory disorders and things. Is there anything that may suggest a sort of reactive process as opposed to the sort of congenital?
Well,
Heglin?
when I first looked at the film, like, they do look like they have increased granulation, and so it's quite a difficult slide because it could be it definitely could be a reactive process here going on here, because the neutrophils look like they have increased granulation. Thus, here and here, there's band forms. So that's when the marrow is starting to pump out more neutrophils, and they're not as matured, but they're still a fully functioning mature neutrophil. It might be an inflammation and infection process, but just my academic interest, I would definitely be referring this one to a hematologist at my laboratory, just going query May-Heglin anomaly. And patients with May-Heglin anomaly do have bleeding tendencies. It can be, I'm not trying to speak for you because you're the expert, you're the hematologist, but they not necessarily severe bleeding tendencies, but they can bruise easily and have prolonged clotting times, like to stop bleeding. And some patients may require therapy, like drugs to increase their platelet production to try to prevent these bleeding tendencies, or maybe in a crisis, like when they have need a platelet transfusion to stop bleeding. So yeah, I don't know, it's a tricky film.
It's tricky but interesting one. I think it's so this patient did have May-Heglin anomaly, and like you said, that generally these patients don't have a huge amount of problems with bleeding, and if they do, it's very mild. But I think the modern way of describing these conditions is related to a mutation in MYH9. I'm not sure whether you've come across these kind of issues. If you had any comments.
So yeah, it's a mutation in MYH9, which is a non-muscle myosin heavy chain structure, and it, like the defect in MYH9 gene causes these non-muscle myosin tubular structures to form in the granulocytes, and they stain a lot like doll bodies, but often in like a rod or elongated shape. And it also causes the slight dysplastic megakaryopoiesis. So that's the formation of platelets, and you get a reduced platelet count and larger platelets and giant platelets in some cases, but they have a normal function. So they do, that's where it would come into. Patients with May-Heglin anomaly often have mild bleeding tendencies and often doesn't disrupt their day-to-day life or cause. But because they're large platelets and you reduce count, I guess when you're you do get a damage to a blood vessel and you start a bleeding occurring, it'll be a less efficient platelet plug that would form. And so I guess that's where the mild bleeding tendencies come into play. Do you have anything to add?
No, I think originally they thought that these were distinct subgroups, things like May-Heglin, there's conditions like Sebastian syndrome, really rare things. There's another one called Epstein syndrome, but they very much run on a spectrum of different clinical associated features. So you can get things like deafness, neurological abnormalities as well, and variable sorts of bleeding tendencies. But the family history is usually very useful, and as well as just looking at previous cancer genetics. Sorry, Joe?
It's an autosomal dominant. So if the child has it, it's almost guaranteed a parent has it.
Yeah, definitely. So, getting the full picture is important in these cases. We've got one comment saying that this could be could this be gray platelet syndrome?
Okay.
I mean, I've never seen a case of that. I'm not sure if you have, Joe, but
no, I haven't. But I've read about it. Like when we get our quality assurance surveys, and you're looking into this congenital macro thrombocytopenias, like and stuff, and you start reading Barbara Bain's textbooks and other wonderful textbooks about morphology, and you come across these rare congenital conditions. So gray platelet syndrome, you would expect to see hypergranular or agranular platelets. That's where the name gray platelet, because basically the platelet would look like these, but you wouldn't get any in these basophilic darkly purple staining granules in the platelets. It would just look like sort of just like, imagine some monocyte cytoplasm that just free by itself about this size or this size. And I'm not sure if gray platelet syndrome even has macrothrombocytes, like large platelets, but don't quote me on that because it's been quite some time since I've read into it. But yeah, gray platelet syndrome, you would be the most prominent feature for the platelets would be these agranular platelets, and you'd be going in the line thinking, is this a dysplastic process, or is this maybe a gray platelet syndrome? It could be a congenital inherited condition. Yeah.
Yeah, I think again, like I said, I've never seen a case of this in real life, but
no.
At least from the textbooks, you can get medium to large size platelets, but as you mentioned, the sort of predominant feature is the sort of lack of granularity and sort of empty appearance of platelets. So excellent. So I think we've covered all the comments that have been made, and any questions as well. I'm just going to share my screen again.
Okay. Do I stop share?
Yeah, if you stop sharing, and if I share my screen.
There you go.
There we go. So, Joe, thank you so much for your time today and your insight into 3 interesting cases.
Oh, no worries.
Thank you.
Sorry, I was a little bit of a nervous wreck.
No, not at all. You did really well. We really enjoyed it. So plenty of discussion stimulated, and it's been absolutely fantastic. So thank you, Joe. Thank you to everyone who participated in today's webinar. I'd also like to thank our sponsors, Urban Mannheim. Just to remind you again that a CME certificate will be emailed to you, provided that you've registered. I'm going to put a link into our post-webinar survey, and we're really grateful if you could complete that, so we can use that as the basis for providing further educational content. You should hopefully be able to watch the webinar again on the Blood Academy YouTube page, and we'll get that video uploaded in the next day or so. And hopefully we'll see you in 2 weeks' time, where we're going to be joined again by Dr. Audi Sitardi from Canada, where we're going to be discussing acute leukemia cases. We've got 3 interesting cases, and hopefully we can stimulate more interesting discussion and comments as well from the guys on the hematology interest group. So Thanks again, Joe. Thanks everyone else.
No worries.
And
Thank you. It's
hopefully
been a
we'll see you
pleasure.
again in 2 weeks' time.
Okay.
Excellent. All the best then.